Hi, my name is Katrina Ellis. I'm an assistant professor at the University of Michigan School of Social Work, and I appreciate the opportunity today to talk about a project that I completed with the Michigan Center for Urban African American Aging Research, or MCUAAAR. The title of the project was Understanding and Supporting the Health of African American Cancer Survivors and Their Family Caregivers. There are a few reasons why I decided to pursue this project. First, middle-aged and older adults represent the majority of individuals diagnosed or living with cancer in the United States. And this project allowed me to think about the experiences of those middle-aged and older adults with a history of cancer in some unique ways, which I'll talk about shortly. In addition, as I noted when I shared my title, the project focuses on Black Americans. And that is because despite many advances that we made in detecting and treating cancer, there are noted racial and ethnic disparities in cancer outcomes that persist. As seen on this slide, Black Americans have amongst the highest rates of new cancer cases and cancer deaths each year. And so it was important to me in this study to focus on and think about the health of Black Americans with cancer specifically. I also wanted to focus really closely on the experiences of family members. Families often play a really key role in supporting someone who's been diagnosed with cancer. And the term we often use to refer to family members or friends who step in to provide support are family caregivers. According to the Center for Disease Control, about a quarter of Black American adults identify as caregivers. And one of the things that interests me is the health of those caregivers. Many caregivers step into the role of caregiver while managing health problems of their own. And so in this study, I wanted to think about ways to both acknowledge and understand the health of people with cancer and their caregivers in order to identify ways that we might better support this population. So the first aim of this study was to understand associations between the symptoms that people with cancer might experience, the symptoms that their caregivers might be experiencing, and both of their quality of life. And by symptoms, I mean things such as pain, fatigue, nausea, distress. And we might easily imagine that the symptoms that people with cancer are experiencing are due to their cancer treatment, the cancer itself, or other health conditions. And for caregivers, the symptoms that they might report at the time of a cancer diagnosis when they're starting their caregiving experience could be related to the stress of caregiving or their own health concerns. So for the first study, this first aim, I set out to examine whether or not there was an association between the symptoms that Black patients and caregivers reported and their quality of life or their overall well-being, and if one person's symptoms influence the other person's quality of life or well-being. The average age of patients was about 60 years old, caregivers about 50 years old, but there was a range there. You'll note with regards to the patient age that this study sample was restricted to just those patients who could be considered middle-aged and older to reflect what we see primarily in terms of cancer populations in the United States. There were males and females in both the patient and caregiver population, but a little bit more females. The patients had one of four types of cancer, so either breast, colorectal, lung, or prostate cancer, which represent the four most commonly diagnosed cancers in the United States. And the people who were caregivers of those patients were spouses and partners, about 73%. Daughters made up the next largest percentage at about 10%, and then sons at 6.8%. And then there were some other types of extended family and even friends who rounded out the caregiver sample. So I'll share first some of the common symptoms or the most common symptoms that patients and caregivers said that they were experiencing soon after the patient was diagnosed with cancer and had started treatment. So the patient's most common symptoms are there at the top, the caregivers right below. You'll see some similarities. So for both patients and caregivers, the most prevalent symptoms that they reported were fatigue. And then we also see sleep as number 3 for patients, number 2 for caregivers. Pain was the second most common symptom for patients, the fourth most common for caregivers. Mental distress, number 5 for patients, number 3 for caregivers. That the most prevalent symptoms for both patients and caregivers were the same, which is really interesting to think about, given that, again, the patient is undergoing cancer treatment, has a cancer diagnosis. The caregiver does not, but they are still experiencing symptoms that reflect the most common for the people who are diagnosed with cancer. And when we think about all the different symptoms that the patients and caregivers reported, some of which are not listed here. So they were also asked about things like nausea, things related to their ability to move around, some other functional things. Overall, we saw that patients were more physically distressed with symptoms than caregivers, but when we look at their mental distress, so how mentally distressed or taxed that they were feeling, they were very similar. We didn't see any difference there, which also is important to think about. The results of this study have been published in the journal called Psycho-Oncology, and the header and the title for that publication is listed there. And I'll conclude my discussion of this first aim with answering these two questions. So how do symptoms influence quality of life? And why does it matter? So we did find that symptoms had an influence on the quality of life or well-being of patients and caregivers. One thing we found was that more mental distress among patients was associated with poorer patient quality of life. Also, more patient physical distress was associated with poorer patient quality of life. In patients' physical distress, so the physical symptoms also had a negative influence on caregivers' emotional well-being. So we see some interdependence or some ways in which the patient's symptoms, physical symptoms, influence the emotional well-being or quality of life of the caregiver. We also found that the caregiver's mental distress was associated with lower caregiver quality of life and lower patient quality of life. The caregiver's physical distress was associated with poor caregiver quality of life and poor emotional well-being and for patients. And more details about the findings are in that article, but to take a step back, we can ask, well, why does this matter? Well, as we can see, there are some symptoms that both patients and caregivers experience that overlap, that are consistently common between them. And this could signal some ways in which we could think about supporting the symptom management of both people with cancer and their caregivers. Our analysis showed that the symptoms of one person influence not only their quality of life, but the other person's as well. And so if we think about interventions or programs that could help them better manage their symptoms or alleviate their symptoms, we can then think about ways in which this might have a positive influence on their quality of life. The second aim of this MCUAAAR project was to examine existing literature to learn about interventions that have targeted improvements in physical activity, improvements in diet, and improvements in weight, so weight loss or management for people who have completed cancer treatment and their family members. So as we saw with the first study, weight loss was one of the more common symptoms for both patients and caregivers. And after someone completes cancer treatment, there may be a desire, a renewed sense of, what can I do to improve my health? And the same might be said by their family members, those who are in a primary caregiver roles or others who are just around them and supporting them. And there are interventions that have been designed for people with cancer after they've completed treatment to support them during this this phase of life during cancer survivorship. But because of my interest in families specifically and the things that we still need to learn about caregivers and families, I wanted to understand what interventions existed to support the health of patients and family members after cancer treatment ends. As noted on the slide, we found literature in many different research databases. And to start off, we had about 2,000 records that we screened after we removed some duplicates. And in the end, we included in this study about 14 interventions supporting cancer survivors and family members after treatment ends. So the two key questions that I want to briefly talk about is, what interventions were currently available at the time of this review for families after treatment ends, and then why does it matter? And the results of this study have been published in the Journal of Cancer Survivorship, so more details are available there. A few of our findings were that most interventions focused on diet and physical activity in combination. The interventions would include people who had many different types of cancer, so not just for people with colorectal cancer or just with prostate cancer. Despite what we know about the different types of relationships that caregivers might have with patients, so spouse, sibling, daughter, etc., most of the interventions were limited to one type of family relationship, so just a person with cancer and their spouse or partner, which I think gives us a sense of where we might think about expanding the reach of these interventions to include many different types of family members. And then also, most of the studies were predominantly with white American samples. We only found 2 studies that had primarily Black Americans, not all Black Americans, but primarily Black Americans. One study with primarily Hispanic or Latino populations. So there are some ways in which we can think about better targeting and tailoring populations of color who we know are disproportionately affected by cancer. And so what we learned is that many of the studies found success in helping to improve outcomes. The way that the studies reported information often led us to learn more about how the interventions helped people with cancer, not as much about family caregivers or family members. So there are opportunities to think more completely about designing and conducting interventions to address and measure health outcomes and improvements for not only patients, but their family members. And so overall, this study signals that there are some great interventions available, but a lot more work that could be done to help people who have had cancer, who have managed cancer, and their families make improvements in their physical health, their diet, their fitness, their weight related concerns after cancer ends. So next steps for this work for me are to continue examining these research questions, specifically with Black American populations, thinking about some of the family interventions and implications for improving the support we provide to families after a cancer diagnosis. And a key component of this work is engaging with families, asking families questions about their experiences, asking them questions about the type of support that they've received, this type of support that they might need or desire, and thinking about ways to close some of the gaps in what we're currently doing in ways that can improve health outcomes and specifically decrease some of the disparities that we see in cancer outcomes between different racial and ethnic groups. I like to acknowledge the MCUAAAR faculty, staff, and other scholars who supported me in this work, funders, including MCUAAAR, and then also the National Cancer Institute, American Cancer Society, who funded the data that I used to ask the questions in AIM-1. I also would like to acknowledge my research team, some of my collaborators in this work, and then also the participants and families who are represented. If you have any questions, feel free to reach out to me at kahe@umich.edu with questions, ideas, thoughts about collaborating. I look forward to and welcome hearing from you. Thank you and have a great day.